I am very, very pleased to have met for the first time today Dr. John Hart, who is going to start us off with the vastness of what this chronic brain disease looks like and why it is so important for us to change the conversation and change our thinking about what recovery can look like. Dr. Hart? This is the clicker.
That's the clicker. Well, you all are in this room today and you have an occupation because of the people in my occupation. I'm a physician. We are the largest suppliers of opioids in Clark County. So those Vicodin, those oxycodones that are coming on the streets, they came from us. They did not come from Mexico. They did not come from some far-off place. They came from your physician. 11 days ago, my wife had surgery for her shoulder. She had a total shoulder done. She was given a prescription for oxycodone. She was given a number 5 milligrams and number 50. What did she take? She took 1/2 of a 5 milligram Vicodin the first night she was home. That's from a previous knee surgery she had 5 years ago that was locked in the safe. That other prescription was never used. That is typical, what we see. We prescribe huge amounts, and guess where they end up? They end up with our kids. Let's get started. Okay, this is our past. So we have a history of abstinence in there. Remember, we knew that this addiction thing was bad because we knew it back with alcohol. My God, it was a moral failure. That was a big thing back in the 20s. They were thumping on all kinds of books and yelling at us. And so we passed the Volstead Act. Then we repealed the darn thing 13 years later. We decided it was time to have a drink. But when we repealed it, we did not get rid of our beliefs. We kept our beliefs. And these still permeate what we do and we treat addiction. I'm hoping today to upset folks. I'm hoping to give you a different framework of looking at this world. Now, AA and NA, do they work? Yes. Okay? But we need to ask more questions. Remember, the only thing that gets us to learn more is by asking why. When I say something, you should ask yourself why. And you should feel free to nail my rear end to the wall. That's what it's all about. Okay. So we went into addiction treatment, $35 billion. This is big money. Eric hit it right on the nose. This is big money. And if you're really smart, you'll get into the business of doing this because there's going to be a lot more money. Now, so if what we've been doing works, we ought to keep doing it, and let's not stop, guys. Let's just ramp it up and do more. But how successful are we? Well, I'm not going to answer that, but I'm going to let this fellow answer it. I think Lance answered it. And this was a meeting, a presentation that Eric put on with SWACH, a month or so ago when he spoke. And he's at McLean Hospital at Harvard, and this is one of the premier places. What's our success rate with what we're doing today and how we treat addiction? That's it. Now, you want your gallbladder taken out. You've got a bad gallbladder. You go to the surgeon. You say, what is your success rate on this surgery? He says, about 5-10%. Well, how about the other people? Oh, yeah, they don't do so good. Would you go? Would you get on his table? We're the surgeons. We're doing this, and we keep doing it because we're not asking why. Why are we doing it? The data doesn't support it. These are all human factors that all of us have to deal with, including myself. Now, is it a disease? Yeah, we all say it is. Is it a psychological disease? What's the answer? Who thinks it's psychological? Let's raise your hands. Where do we get there's a hand. She's one honest lady in this group. It's an opioid use disorder. Where does that come out of? What's the book? The name? Yeah, DSM-5 now, I guess it is. Of course, I was brought up on 3. We're at 5 now. It's a psychiatric people did this. I'll let you decide That's correct. Well, let's talk about what's going on in the brain when we deal with opioids. Okay? This was a nice study. I sort of love this one. They took 10 people with chronic low back. They gave them morphine for 1 month. Then they stopped the morphine. Before they did it, they did a fine resolution scans on their brain to measure the size of the nuclei in their brain. They then gave them 1 month exposure to morphine. They took them off. And what they found out is when they scanned them right after they'd been off morphine, they had some shrinking of 12 regions in the brain, including the amygdala. So this actually caused a change in the physical size. Now, so they said, let's rescan them. They did. In 4.7 months, there was no change. Wonder why we have problems. But let's go further. I love this one. I'm not sure how to use this thing. We'll try it today. Oop, I did something wrong. I pushed the button on the top. What did I do, guys? Oh, there it is again. Where's the pointer? This thing in the middle? Thanks. Okay, this is a normal brain. This is a PET scan. And what's kind of cool about this, see this purple area? That means no dopamine. And it should be like a horseshoe in the middle and 4 eyes. 1, 2, 3, 4 eyes there. I've got a central tremor, so you're going to see this thing flying around. But so that's what the brain looks like. And those are the areas. The purple area means they have no dopamine. And that they're normally not supposed to have dopamine there. That's what a normal brain looks like. But we're going to put them on some narcotics. Now, they can either come from, of course, this guy here and this gal. I know they're drug dealers. So they can either come from you folks, or they can come from someone like me who has a stethoscope and a white coat. And let's just, because the brain doesn't really care who the supplier is. This is what it looks like later. So we lose the receptors. So what's happening when we expose the brain to opioids and a few other substances we're going to talk about, what we get is this huge amount of loss of dopamine receptors. It's purple brain, purple brain. Anyone old enough to remember Prince's song? Yeah, one guy. Paul, you and I are it. Let's go, brother. I know. The young people, they say, who's Prince? Okay, one of my buddies. Okay, and these are called the dopamine, these are the D2 receptors. And these are words I want you to get used to, because if you're one of my patients, you can talk about D2 receptors. My patients can talk about dopamine. My patients can tell you where the receptors are located in the brain. Why would I do that? I want them, because I'm lazy. The more they know, the least I have to do. So let's see what goes on here. So this is basically what happens. This is my brain. It's only got 100 receptors, dopamine receptors, and it goes from 0 to 100. But you break your leg or something, and the doctor says, I'm going to put you on some 40 morphine equivalents. So it puts me on 40 morphine equivalents. The brain says, that's too much dopamine. You don't need that much, but I can't stop it because the guy keeps taking the pills every day. I know what I'll do. I'll turn off the receptors. I'll shut off some receptors. And so it does that. It shuts off receptors. And so we lose receptors. This is purple brain disease. That's what you're seeing up here. But the physician is brilliant. He says you're just getting tolerant. You're getting used to it. It's tolerance. It's a medical word. And many of you have heard this with yourselves and your family and your friends when you're put on chronic narcotics. Or your physician said you're getting tolerant. That's okay. But it's, the pills don't work anymore. The doctor says, well, take 60 milligrams. And I take 60. I feel better. I feel good. I got enough dopamine now. Now I'm beating these remaining receptors. I'm beating these to get the extra dopamine, but it took 60 milligrams. But guess what the brain does? It says, I've had enough of this crap. Didn't I talk to you about this before? Bingo, more. But the doctor's a genius. Gives them 90. Substitute a drug dealer, substitute a doctor, there's no difference. The brain doesn't really care. Cool. Let's get some clinical math. This is for the medical people like me. This is one of the slides I use for the doctors. Guy has some back pain, gets some something, and we put him on some pills like that, 40, 20 milligrams. But this guy, we see him 3 years later, he's on 180 milligrams per day. Well, why? Because he has pain. He has chronic pain. Of course, it could be the person on the street over here saying, because I feel lousy. They're the same thing. The doctor doesn't know that the difference is 160 milligrams. So he was 20% of that, 20 milligrams went for the pain, 160 went for a purple brain disease. That's what's happening in the medical world, and every doctor out there practically believes this story, that I'm treating pain. No, they're treating the damage to the brain. Brain doesn't really care. Treatment's the same. Wait a minute, are you saying I can treat pain? Patients who say they have pain, been on narcotics for 10 years, well, by prescription, by their physician, and the treatment's the same? It's the same brain. But it's my back that hurts, not my brain. We'll talk about that later. So, what we've got here, we put them on a full agonist, which is this is one of my medical slides. You know, it means any of your favorite narcotic, oxycodone, morphine, fentanyl. Fentanyl's fantastic. And basically, you knock off a bunch of receptors. The person says, you get a lot of purple tissue up there. That means it's not working worth a hoot. The person says, I need more. And they're logical to do that. It's illogical for that person to tell me that with a brain like this that I don't need more. If someone tells me that, I look at them, I say, you're lying. Or you're crazy. And I've got a pretty little thing. So you've got to use a lot of narcotic because you only got a little tissue left. And you lose more. So this is what happens. So once again, same pictures. That's what happens. So what does dopamine do? We've talked about dopamine, but we didn't talk about what dopamine does. Let's see what dopamine does. Well, first of all, it helps with pain in my business. Helps with emotion. I feel better. Sometimes I get up and do things if I'm on some morphine or something. And hey, you give me enough, it brings me some pleasure. So it has a value out there. Okay. Now, what happens if I wipe out a bunch of receptors and I can't get enough dopamine in my brain? The opposite. What you get is I'll get pain, I get depression, I get anxiety, I get loss, I get all these things. You can read that. And they will struggle to maintain the normal amount of dopamine. Daniel struggles here by telling his doctor, I have more pain, my back's killing me more, and we increase your prescription. But Paul over here goes to his dealer and says, you got anything stronger? They're the same thing. It's the same problem. This is organic tissue. Why do we put organic tissue disease in DSM-5s? Why do we put them in psychiatric literature? You're saying, well, wait a minute here. Let's talk now, John. You're talking about the bad stuff. You're talking about the narcotics. We've got other people. We've got people on cocaine, a little meth, a little alcohol, a little heroin, you know, name it. Let's take a look at those. This is a normal one. Controls. This is what they look like when they've been exposed to cocaine, meth, alcohol, heroin, and smoking. Brain doesn't really care. They're all using the D2 dopamine receptor group. Okay? Norvokov, who's the head of NIDA now, our big organization in Washington. And this is one of her slides. I stole it from her. She was kind enough to loan it to me. Over here, a lot of dopamine receptors. We expose them to a lot of dopamine, and the brain says too darn many receptors. I'm going to shut down the receptors down there, and that's purple brain disease right here. That's what's happening. Okay, this is another one of her slides. I like this one too. And this is, you notice whether I'm talking cocaine, alcohol, narcotics, all the D2 receptors, they're all the same. It's not rocket science, guys. So here's what normal looks like, but kind of look at it, and this is normal. I put them on cocaine. I kind of wipe out all my good receptors up here. Cocaine's nice because you get a big spike of dopamine. It just crashes the receptors. I tell my patients, you know, they come in and say, Doc, I need some morphine. I said, no, you don't need to. You get some coke, baby. You're going to get a bigger spike better than anything I can do. If you can't get it, I said, you need to come on, talk to me. We can get you some morphine that gives you a better curve like that. And if you're really out of luck and you can't get anything, go out and have a smoke, which is dopamine on a stick. That's what occurs. It works for about 20 minutes, and that's all. So what we see here is 1 month, no difference. So we take people off of medications. We kind of think that they're of a moral failure. They did not do the right thing. They did not attend group. They did not go to the meetings. They did not do your counseling. They ignored everything you told them. They get a brain like this, they shouldn't be doing those things. When you have poison ivy and you're broken out with welts and all over, and you go to the doctor, what are you going to do for my poison ivy? And the doctor says, well, you know, that'd be gone in about 3 weeks if you do nothing, so just don't scratch it. And we tell people not to scratch it all the time. My don't be stupid slide. This was slides I gave to doctors because we tend to think, we do this all the time. This is one of their slides. And the thing is, we see this in their medical record. Joe has had a problem with alcohol, hasn't drank in 10 years. But he's had a lot of back pain, he's had 2 surgeries on his back, but I can put him on narcotics. How long have you been on narcotics, Joe? 10 years? I wonder. This is a normal brain. Again, you can't read it. It's the D2 receptors. This is what it looks like when alcohol hits it. It just virtually, the colors you got in your mind, you got to flip colors here. Purple goes out the door here. It's the reverse. But what occurs there is that's a loss of dopamine receptors. So, you know, I tell patients, you're going to show us, if someone says they're drinking, and I don't do addiction. That's not my, it's not my gig. That's your all's gig. Yeah, I don't do addiction. I just like to read a lot of stuff. And have alcohol problems. And I say, Joe, you got to get off that damn alcohol. Go get some heroin off the street. He said, why, Doc? I said, both of them are going to take your brain out, but at least we can transplant your liver if you have heroin. It'll be good. Alcohol is going to kill your liver. They look at me and say, are you kidding me, Doc? Well, actually, I'm not. But I do say that sometimes. Get the same results. Now, this is gorgeous. This is brilliant. I think she is, I think, this is Thanos'. I think he's out with Volkov out at Brookhaven. This is a rat. This is a Sprague Downy rat. This rat is genetically bred to like alcohol. Okay, so you got an alcoholic rat. You give him water, you give him alcohol, he'll take the alcohol. Okay, that's what he'll do. You got him fixed. So what they did is he puts a micropipette into the brain, puts in a D2 receptor gene, puts a gene into a virus and puts a virus in the guy's brain. He's transplanting a genetic transplant to give the guy dopamine. Wow, what a stupid thing to do. It's just going to kill a rat. Let's see what happens, though. I can't believe they did this. I can't believe they even thought it up. Here's what happens to his dopamine on day 1. It goes up, and then over 10 days, it extinguishes down, and then you re-inject them again. You get the same thing, and it repeats itself after that. But by the way, someone's asking, how's the rat's alcohol consumption? The lower portion, that's his drop in alcohol consumption. Do you see a relationship here? It is 1 for 1. You give them the dopamine receptors, the alcohol stops. Yet, this is a psychological disorder. Let's do another one. Let's have more fun. This one up here. Monkeys are group people. They do well in groups. And they were in herds, like we're here, we're all around tables, we're in groups. That's monkeys. I guess we're all monkeys. So what you do is you want to really hack a monkey off. What you do is you put them in you put them in individually housed away from the group and look at their dopamine levels. Lousy dopamine. Then you throw them into a group setting, and some of the monkeys will become dominant monkeys. Some of the monkeys will become submissive monkeys. Okay? Now we have dominant, submissive. We know what they look like beforehand. We then are going to give them something to play with. We're going to give them some cocaine. Why? We get big spikes. We like to use cocaine in dopamine research because it's quick acting. It works fast. So you give them that, and what happens is they both take it. But after that, the submissive one will take it again and again and again. They like it. The dominant one that's got gobs of dopamine up here says, what the hell am I taking that for? It's a waste of time. Whoa, I love that. So I see the word stress is up there. We're going to see this word later. It has to do with chemistry. So really, When I look at my patients, when I get a new patient, I'm just really deciding, are they a dominant monkey or are they a submissive monkey? Which one are they? What's their dopamine receptors? That's all I ask when I see a patient. How many receptors do they have left? So, and are they going to get them back? And what can we do to help them? That's all we really care about, is receptors. Low dopamine monkey, high dopamine monkey. Okay, opioids goes up, receptors go down. Just the way it works, guys. Can't beat it. Okay, this is from, who's my drug dealer? You're the drug dealers? Okay, those are these guys. This is what they do to the brain. Daniel, you're the doctor. You say, wait, that's the same slide. Of course it is. What kind of idiot do you think I am? Okay, now let's talk about behavior. If you do things to the brain, beside all that drive, when you do things to the brain, you expect to have some changes in their behavior. If they didn't, we wouldn't be in business, would we? Because we see behavior, and that's how it got into the DSM-5. That's how it became a psychiatric disorder, is because we didn't see these scans, we saw behavior, and then we made inferences from their behavior that this is what we should do with you. Probably put you on antidepressant or something. That's what we do lots of, which the research on really is lousy. So this is the portion of the brain right here we want to take a look at. So a few of your patients and clients may have some impulsive behavior. Now, I was kind of coming across a bridge this morning, and I was running a little, I thought I'd be a little late. I was kind of afraid. I didn't want to disappoint everyone, or maybe make them happier too. But I thought, well, you know, I could probably just, if I'd speed up, go about 70 or 80, I think we can get across this bridge pretty fast. But you know, I didn't do that. I decided to follow the traffic and go. So I suppressed that idea, and I had no difficulty doing it. Okay. Because the orbital frontal cortex is what it's all about. When you knock out the dopamine in the orbital frontal cortex, you get impulsive, and then if you knock out more, including this portion of the brain, you get compulsive intake. It's basically brain chemistry. That's all it is. It's so sweet. Now there's another receptor. There are 3 opioid receptors: mu, that's dopamine; kappa, and delta. I'm not going to talk about delta. We don't know anything about it. Kappa, let's talk about kappa. What's kappa do? Okay? It grows with opioids. It likes it. But it gives you pain. It may give you depression. Now, just a few words on this. I've got, I think, 6 patients now that we're treating with Suboxone for one reason: depression. They were suicidal. They all had a previous history of high-dose narcotics. They were taken off and they became suicidal. We put them on Suboxone to maintain them about 8 milligrams a day, and for years now, suicidal is gone. Interesting. Literature out there is very poor on this. Some of the recent research sucks. Okay, so kappa increases with narcotic use. You don't want kappa. Got it? That's the name of it. Let's talk about stress. We saw the word trauma before on the slides. Think of trauma, think of stress. What does stress do to it? Well, the way I was taught classically is that person has stress, they have some anxiety, I put them on some Zoloft, I give them some benzos. I love that. I'm kidding, of course. But that's still how we do things. We put them on those because and then we send them to counseling. And counseling has a value because if you learn to reframe this and approach situations differently, you do not get what I'm going to show you. What does stress do? Stress may increase kappa, which throws up depression, or decrease dopamine. There's a whole group of studies on this. No one's ever reading these studies, but they're out there. They're all over the friggin' place. So when stress happens, there's actually chemical changes in the brain. And it's dealing with the 2 chemicals we know about. Now, you've seen this, that your patients and your clients, they'll be doing well, they're in recovery, and all of a sudden something happens in their life. You know, my girlfriend, shot my dog, stole my pickup, the story. And they have stress, and I went back to drinking. I had some drugs. And we all know this. You and I, we all know this. Reinstates the behavior again. But it occurs because of neural changes in the brain, the chemistry. Now, this one, Ben did this one, and he said it's tied into the serotonin genetic. Okay, Zoloft, Prozac. I'm kind of not sure this is valid. We'll wait and see. So when someone says something's going on in their life, they're requesting more narcotics, I just say, oh, yeah, okay, you're back. But I want to hear about what's happening in your life. Then I know why they have more pain. Then I know why they're wanting more narcotics. Then I know why things are falling apart. It's because of that. That's what it comes down to. When I get stressed, there's chemical changes in the brain. How many patients have told you, and clients have told you, this happened to me, I went and had a couple of drinks and I felt better. Of course they did. They just kicked out the dopamine up again. They like it. It makes good sense. Not to have had that drink would be illogical. This is just more stuff saying the same thing. Stress, we're going to hear trauma today. Think of that. What's happening in the brain? What's the chemistry going on? So I ask people to think about that. How do we know they have cell loss? How do you tell it? It's pretty simple. We call this tolerance. Other people call it addiction. It's the same thing. Okay? How do you tell they've got it? Do you do a PET scan of the brain? Nope. You say, well, that's bad behavior. They took more pills. They ran out early. I say, what's normal? They didn't have enough dopamine. That's why when you supply enough dopamine, all this stuff stops. What we historically have believed is that if we take you through recovery, remember, it used to be a 7-day period, you went in there and came out 7 days, family is all happy, they greet you, you're now been detoxed, you come out of the unit 7 days later, and of course you know your relapse rates, higher than the sky. Of course, the receptors haven't recovered. Recovery receptors takes years. That's why programs take years. You're not going to do it in a week. So we came along with Suboxone, we put them on Suboxone, we did all kind of studies with Suboxone. We took them off after 1 week, we took them off after 1 month, we took them off after 3 months on Suboxone, relapse rate's the same. It's years. When you're running on empty receptors, we stopped the opioids, we left the receptors empty, and they're not functioning. So until you get your receptors back, you should expect that. Okay, how do you predict people are going to have problems? Well, this is on some lousy studies, but it's really interesting. The kids, if they smoked before the brain matured, then it was considered 16 or 18. Now it's about mid-20s. It probably changed the dopamine receptors. But we know that we didn't know that, but we know that it made huge differences. If they smoked a pack of cigarettes a day before the age of 16, which is really kind of rare out there, what's their chances they're going to use cocaine or drug of abuse later? 100 times normal. Wow. The brain wasn't mature. They insulted the brain. They knocked off receptors. And then they get their first Vicodin and they go, God, I feel normal for the first time. And I've heard that. Okay. Genetics, the other question I ask them is simply this. Tell me about I want to know your grandparents, your parents, your brothers and sisters. It's an upside down T. Okay? I want to know who has a high dose who uses a lot of narcotics or for any reason or alcohol. Give me 2 or 3 of those and you kind of know your genetics. Remember, some monkeys are born with a different number of receptors. And we can genetically breed our rats in 3 generations. We can make our rats become alcoholics by selective breeding. How many times have I sat in the clinic and heard this? I ask about their genetics. They tell me, well, I'm this way, and my parents were this way, and my grandparents were this way, and I met my husband in a bar. What's the chances of genetics playing a role? Pretty good. Let's talk about Suboxone. Here's what receptors look like with Suboxone. 16 milligram. This is what a normal brain is here, okay? We're going to start clouding up some of the receptors here and follow the pathway down this way. 2 milligrams makes a big difference. 16 blocks out practically, it's 92%. So magic number. Knocks out 92% of the receptors. That's why 16 milligrams of Suboxone is the most common number, starting people on. Now remember, the longer they're on Suboxone, they're going to recovery of receptors. Because here's what happens. Take that same purple brain we saw before, I put them on Suboxone, you get all this dopamine, they get normal amount of dopamine, but the magic is this. The one on the left, the urge is gone, it's gone, but the magic is simply recovery of receptors. That's why you can lower the dose on Suboxone. And as you go over time, you can lower the dose because receptors are back and the excess Suboxone is being wasted, or they can find out, I don't need this much and I can sell the rest. Okay. So Suboxone has some advantages. It's anti-kappa and it's pro-dopamine. Okay. That's what it does. This is a big question. Does Suboxone treat addiction? You know I'm setting you up with this. You know I'm setting you up. Doesn't treat addiction at all. All it does is this. That's all it does. And sometimes that's enough. And sometimes that's all they needed. So, we take you off your stuff. Guess what? Burning collapse. Put them on Suboxone. We've got about a 75% maintenance out there a year later. That's pretty darn good, folks. That's certainly better than 5 to 10% success rate. Now, you know, speakers always give you their favorite slides, but not all of them are this perfect. This one showed a 50%, but you know, I'll still take those numbers. I'll take them. If I keep doing the way we usually do things, it's a major error. So this is out of the end here. We don't treat hypertension and stuff by exercise alone. We don't do that. We give them blood pressure pills for their blood pressure, and we recommend they see a person, or we recommend they go to the gym, or whatever we recommend, but we don't force it, because it never works when you do that. And why do we keep doing this? Why do we keep people looking at this as this is really a brain disease and it's due to tissue changes? Why do we put this huge amount of efforts in forcing people to do things when we could have done something different and taken a different approach? And that's why I'm here to shake folks up. This is what we do now. You come in, we assess your behavior, we put you in behavior treatment, we may or may not add Suboxone to it, because that's based on our historical understanding of how addiction was to be treated, and that came from the psychiatric side of the world. Consider this. Give the pill first, treat the tissue. If the behavior is extinguished, continue the pill, forget everything else, just give them the pill and that's it. What if we did that? What if we gave the pill first, some of the behavior continues, we add behavior treatment and treat the behavior, because that's what's required. Why don't we do it this way? I don't know. Thank you.